Bismillahirrahmanirrahim. I am Dr. Sayyid Raza Muhyiddin, member of the visiting faculty, Times Institute, Multan for MPH classes. And today is the 8th lecture of health communication, health promotion, and health education. And today we will study the concept of hierarchy of evidence in this health promotion. And as you know, the hierarchy is like a pyramid, and health promotion, as you know, these are the activities, these are all functions which are done to improve the health status of the people. So what is hierarchy of evidence? We see that there is are certain epidemiological studies in which give you some concept, or which tell you anything that is the health promotion strategy, or health promotion program. So hierarchy is, in certain programs, your inference is at some level, and then you selectively go on higher level for the better results. So the quality of evidence is lower on the lower side and the higher on outside, but the risk of bias is lower on the higher side and higher on the lower side. So there are systematic reviews and meta-analysis of RSCs. So these editorials and expert opinions regarding health promotion or any health activity, this is the lowest level of the study. Then there are mechanistic studies. Then on the top there are case reports, case studies, and then normally cross-sectional study. Then on the surveys. Then on the higher level is case control studies. Then there are cohort studies, and then there are the randomized control trials, and on the top of systematic reviews and meta-analysis of RCTs, that is randomized control trials. And then you see, what is hierarchy of evidence? A hierarchy of evidence, or level of evidence, is a heuristic used to rank the relative strength of results obtained from scientific research. So there is a broad agreement on the relative strength of the large-scale epidemiological studies. So more than 80 different hierarchies have been proposed for assessing medical evidence. So what does the hierarchy of evidence mean? The hierarchy of evidence is a weighting of evidence given to the design of a quantitative study. Those studies that fall at the top of the hierarchy are considered to be the gold standard. Studies that have used these designs provide the best evidence for researched area. So I told you before that the studies which are on the top level, it's randomized control trial, then it's meta-analysis, they are on the top, and they are known as the gold standard studies because they have less bias and the greater purity. Then are the levels of evidence. The level of evidence, these are sometimes also called hierarchy of evidence, are assigned to studies based on the methodological quality of their design, validity, and applicability to patient care. These decisions gives the grade or strength of the recommendation. Whatever you recommend, these studies give you the grade or strength. So the there are these, I tell you, certain levels of evidence. The first level is evidence from a systematic review or meta-analysis of all relevant RTCs, randomized controlled trial, or evidence-based clinical practice guidelines based on the systematic reviews of RCTs or three or more RCTs of good quality that have similar results. This is level one. Then the level two is evidence obtained from at least one well-designed RCT, randomized controlled trial. For example, a large multi-site RCT. Then the level three is the evidence obtained from well-designed controlled trials without randomization. It's quasi-experimental. Then level 4 is the evidence from well-designed case control or cohort studies. And level 5 is evidence from systematic reviews of descriptive and qualitative study, meta-synthesis. Then level 6 is evidence from a single descriptive or qualitative study. And level 7 is evidence from the opinion of authorities and reports of expert committees. And all this you have studied while studying the epidemiology and epidemiological studies and the surveillance systems, etc. Then there are research study designs. Different types of clinical questions are best answered by different types of research studies. You might not always find the highest level of evidence, that is the systematic review or meta-analysis, to answer your question. Sometimes the question is small, at a very smaller scale, so when this happens, work your way down to the next highest level of evidence. So, all the levels of evidence are, they are in vogue, they are, they are useful, and it depends upon the type of question or the type of problem to be answered. Then I give you certain research study designs best suited to answer any type of clinical question. Like clinical question is all clinical questions. So what is the suggested research design is systematic review, meta-analysis. Therapy is clinical question, US randomized controlled trial, you want to, there's a drug therapy or some, other intervention. Immunotherapy, the answer is randomized controlled trial, meta-analysis. A cohort study, a case control study, and a case series can also be the answer. Then is the question is the etiology of some condition, so the random is RCT, meta-analysis, cohort study, also case control study, case series. Then for diagnosis, there are the random RCT, also cohort study. For prevention, RCT, also prospective study, meta-analysis, cohort study, case control study, case series. For prognosis, cohort study, also case control study, case series. So now for prognosis, the level has decreased. So for meaning, qualitative study, and for quality improvement, RCT, also qualitative study, and for cost, the answer is suggested research design is economic evaluation. So the type of resources in this is, for, this systematic reviews, case control study, and or when the quality of evidence is increased, here is the, the resource is filtered information. For the higher level, the resource is a filtered information. For this middle level, that is randomized controlled trials and cohort studies, both infiltered and this database searches, simultaneously, and for the case control studies and background information, only unfiltered information is the source. And what are the types of resources when searching for evidence-based information? One should select the highest level of evidence possible: systematic reviews or meta-analysis. Systematic reviews, meta-analysis, and critically appraised topics. Articles have all gone through an evaluation process. They have been filtered. Information that has been critically appraised is considered unfiltered. So, the types of resources, as you move up the pyramid, however, fewer studies are available. It is important to recognize that high levels of evidence may not exist for your clinical question. If this is the case, you will need to move down the pyramid if your quest for resources at the top of the pyramid is unsuccessful. So, these are all meta-analysis, critically appraised articles, cohort study, case control study. So you can get the outcome of your interest in this type of resources. So now the second topic is, this was about all about the hierarchy of evidence. Now another model of health promotion is outcome model of health promotion. In this outcome model of health promotion, you see there are the health promotion actions. These are education, facilitation, and advocacy. Then there are health promotion outcomes. These are health literacy, social influence and actions, health public policy and organizational practice. And then are the intermediate outcomes. These are health lifestyles, effective health services, healthy environments. And then health and social outcomes are the quality of life, functional independence, security. Then there is the mortality, morbidity, and disability on the negative side. Then you see what is the evaluation framework for health promotion. The topic is this: Wimbush and Watson in 2000, they proposed an evaluation approach which recognized the contributors to theory and quality as well as effectiveness in program development. The framework in this builds on the work of the Health Education Board for Scotland, and it identifies the different stages and forms of evaluation which contribute to the development of effective interventions. So, if you see the framework, there is the stage one is the planning, and the focus is learning from other evaluations of effectiveness, then option appraisal. And the questions are: what are likely to be the best ways of addressing a need or problem with a group or setting? Then the stage is design and pilot, and in which the feasibility of proposed approach, theory of change, is the evaluation focus, and the questions are: is the proposed program feasible and acceptable? What outcome can be achieved in what time period? How and why will it work, and how it can be adopted to maximize effectiveness? Then there is a stage of implementation. It is early startup, and its focus is to deliver in quantity assurance, monitoring and review systems. And for this question, as we track, what are the problems to be addressed, what actions to be needed to improve the performance. Then the next stage is implementation establishment. For that very purpose, our focus is implementation process to reach and program impacts, and then here the question is: how is the program working? Is it being implemented? The target population being reached? Are program objective impacts being achieved? So this then is the implementation and fully operational. So in this, the focus is on the intermediate outcomes, so and effectiveness. And then in this The question is to what extent were intermediate outcomes achieved and how were they achieved in which groups, and then is the what can be the benefits. Then for each and every this model there is after this is dissemination. So the evaluation focus is the replicability of outcomes, generalizability of outcomes, and this the question will be that can be programmed by transfer to another setting or population for to achieve the same outcome. So this is the outcome model of the healthcare promotion. So thank you very much.